Test. 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 Test.
We can hear you, Stephen, and no song, please, Claire. Oh,
Yes, I can hear you. Marco
yes.
Tallarico.
Okay. I will mute again.
Okay, very good.
Stephen, it's clear. Now, only one person is in the waiting room.
Two.
Okay.
Two right
So I
now.
think
Okay, I will just press to the second slide for the awesome video.
okay.
Endlessly striving for better technology, OSTEM Implant is maintaining its unbeatable #1 place in the domestic implant market and making its way to becoming the top global dental company. Enhancing the quality of medical treatment for both dentists and patients with leading technology and proven quality. OSTEM Implant. OSTEM Implant aims to improve human health by sophisticating the treatment technology available for dentists. With a determination to help anyone operate successful treatments, OSTEM is persistently seeking innovative advancements in implant technology. We have acquired FDA and CE approval subject to strict global standards. OSTEM is recognized for its technology and quality in both domestic and global markets. OSTEM has maintained its global #1 place in implant sales since 2017 as a distinctive brand most frequently used by clinicians around the world. OSTEM's innovation goes beyond implants, extending to all products and services for dental diagnosis. Products include Korea's top-selling dental unit chair, dental equipment such as CT with high-quality images, the most similar bone graft material to human bones, and dental resources including impression materials and orthodontics materials. Dental pharmacy services comprise comprehensive oral care and treatment solutions. Korea's top-selling dental software, such as the electronic chart, dental office management software, and examples of the wide-ranging products provided by OSTEM. Furthermore, OSTEM provides a dental office interior design solution that takes patient convenience into consideration. The solution ultimately contributes to create the ideal clinic environment. OSTEM, the digital dentistry leader, offers innovative digital technologies and products including computer-guided surgery, milling machines, 3D printers, and digital orthodontic lineups. OSTEM's corporate dental portal, Dental, has been spotlighted as a one-stop platform that provides services and information including education, news, recruitment, and software for clinicians. Advanced technology and premium quality are the drivers of OSTEM's development as a global dental leader. Securing a high-level dental laboratory, Central Lab, OSTEM now operates 15 dental R&D centers and invests 11% of corporate revenue in R&D. Top dental R&D researchers are striving to develop technologies and products that will lead the global dental industry. As a result, OSTEM has successfully established top-level implant technology and the largest implant product lineup around the world. OSTEM, the digital dentistry leader, established an R&D team for digitalizing dental treatment and proved its capability by setting up full digital dentistry product lines of equipment, materials, and total management software that can manage all clinical steps from diagnosis to treatment. While maintaining top-level quality, OSTEM has established global production bases in Korea, the US, and China, and is cooperating to achieve a better quality assurance system. OSTEM established strict quality management system, which includes high-tech production automation system, total inspection system, and quality tracking system for each process. Performs strict quality control inspections for each production process and product to meet the highest standards. OSTEM also contributes to society. OSTEM's clinical education programs are designed to assist with providing better treatment for both clinicians and patients, and extensively contribute to clinical development for clinicians all around the world. Moreover, OSTEM is continuously expanding its social contribution by sponsoring community service activities and dental academic organizations. OSTEM is also donating scholarships to dental schools and graduate schools for clinical dentistry. OSTEM currently has 13 business sites in Korea as we continue to expand our network globally. The headquarters and central research lab, which is located in Magok, Seoul, is maximizing synergy by unifying R&D capabilities in all fields of dental services. OSTEM is leading the global dentistry industry by expanding its global network to US, China, and Europe, running branches worldwide and exporting products to more than 80 countries. OSTEM is securing the world #1 implant sales company status by experiencing remarkable growth every year. OSTEM Implant's vision does not stop here. OSTEM Implant will strive to develop better technologies to lead the global dental industry that will contribute to healthier life in the era of 100-year human lifespan. OSTEM Implant will advance to become the global #1 implant company by 2026 and global #1 dental company by 2036. A company that is growing endlessly to become the global #1 in the dental industry. OSTEM Implant.
Hello, everybody. Hello, Professor.
Hello.
Hello, Professor Marco. How are you? Welcome
I'm
to
good.
our third webinar.
Thank you.
Okay, and welcome everyone. My name is Steven. Same again introduction again for the new guests who didn't attend the first and the second webinar. So this is our third series of the webinar that is held by Professor Marco. It's about digital dentistry. Today, we will talk about the execution of guided surgery and immediate loading. It was a case that we already spoke about last two webinars, and this will be clinical cases as promised by Professor Marco. So, a brief introduction about Professor Marco again for the new guests. He is a DTS and a Master of Science in Oral Surgery. He's a director and research project manager of Austin, OIC, Italy. He's certified in implant-based therapy in European Association of Osseointegration 2013. He is assistant professor at the Department of Medicine and Surgery and Pharmacy, University of Sassari, Italy. Expert in digital solutions, more than 100 publications in peer-reviewed journals, private practice limited to dental implant and orthodontic in Rome, Italy. So welcome, Professor Marco.
Okay, I'm ready. Thank you, Stephen.
Okay.
Thank you to all the
Welcome.
OSTEM Middle East. As I promised, today I want to show you clinical cases with immediate loading for full arch restoration. I'm sorry for my outfit, but I'm at work, maybe with most of you, because today is a working day, it's afternoon. So thanks to dedicate time in this period. Really quickly to my introduction, Stephen already did it. I live in Rome, and I will be very happy because I will visit Dubai for the first time next February for the Congress of the OSTEM Middle East. This is my clinic in Rome. I love digital technologies and training activities, particularly guided surgery. In the previous webinar, we spoke about digital dentistry in general and data collection for guided surgery. In the last webinar, the second, we spoke about software for guided surgery, and we focused on single implant planning and execution. And we watched some clinical cases. Today, I want to focus on complete arch restoration. Before showing to you 3 clinical cases, I would like to introduce the surgical kit, OSTEM One Guide. We already spoke about the surgical kit last time. Just 1 second that I will change my camera. Okay. Stephen, can you see the kit? Okay, perfect.
Yes, we see it.
Yes, perfect. Okay. So we already spoke about the guided surgery and the surgical template in the previous webinar. However, I want to highlight that OSTEM use one of the most beautiful kits in the world, and maybe also a lot of solutions for guided surgery, because OSTEM provide the one guide kit. This is the surgical kit for conventional implant placement. However, we also have one MS kit for narrow implants, one CAS for sinus lift approach through the templated or the solutions. Moreover, OSTEM introduced the surgical template without metallic sleeves. In a series of publication, randomized controlled trial, systematic review, meta-analysis, I demonstrated that surgical template without metallic sleeves are more accurate than surgical template with metallic sleeves, and that also more easy to print in office.
Excuse me, Professor, can we increase the screen, enlarge the screen? We can see the PPT on the big screen.
I'm sorry, just 1 second, I try video. Okay, Black Magic. No. I don't know. I'm sorry, you have now select that magic camera. I don't have PPT, so just okay, stop to share. I'm sorry. This is the problem. Now you can see the screen, okay?
Yes.
Yes, okay, I'm sorry because I didn't stop to share. Okay, this is the one kit, and these are the surgical template without metallic sleeves. Moreover, today I will show you some cases also with the stackable or multi-piece surgical template like this. So it's possible to remove for different solutions such as bone reduction or immediate loading, for example, making guided surgery for complete arch restoration easier. Very quickly, in 5 minutes, this is the surgical kit. On the first part, these drills are for mini implants and regular implants, 4 millimeter of diameter and 4.5 millimeter of diameter. In the middle, we have the drills for the 5 millimeter drills, and 5 millimeter implants. On the right, we have some tools. Most important is the initial drill. Initial drill is a shortened drill of 2.2 millimeter of diameter, because if we use the normal drill immediately, flap or flapless approach, the drill touches the bone and is not guided. The initial drill allows to prepare the bone and to be guided, and then changing the drill, the next drill will go through the prepared holes in order to have a double contact, improving the accuracy. So the initial drill is the first drill that allows to prepare the bone, improving the accuracy of longer drills. Then we have the drill of the working length, and then we move in order to make the diameter wider. According to the final implants, the one guy kit works with the concept of 1-2-2 kit. We also have the 1-2-2 taper kit, that is the kit for the conventional implants. The drill are the same, have the same shape. For the guided surgery, the drill are longer and are guided, of course, but the drill of the shape is the same. I would like to spend a few time because I very love this drill. These drill are a little bit narrow on the apex, a little bit wider on the crestal part, are steps. These allow to under-prepare a little bit the apical portion of the implants and to over-prepare a little bit the coronal part. Why? If we under-prepare a little bit, we can improve the primary implant stability without creating compression of the bone in the crestal area that can come to resorb. And if we prepare a little bit more in the crestal part, the same, we avoid any kind of compression. Then the apex is narrow, the crestal part is wider. We can also skip, for example, from this one to this one. We can skip one drill without creating any mobbing on the bone, because the apex is narrow, the crestal part is wider, so the crestal part can go in the bone and then finish to prepare. However, I don't like to skip the drill. Of course, you can, particularly in the medium, poor quality bone or in the soft bone. But most important is under preparation in the apex in order to improve the primary implant stability, particularly for immediate loading, and over preparation in the crestal area in order to avoid any kind of compression. Then we have another possibility that is to under and over prepare vertically, not only horizontally, wandering less, wandering more. For example, if we have 4 millimeter diameter, 11.5, and we want to improve the primary implant stability, we can reduce the length of the preparation, for example, 7 millimeter. In case of D1 bone in the mandible, we can over prepare vertically in order to avoid excessive compression. Cortical drill is only for the 4.5. Why? Because if you need a cortical drill for the 4 millimeter diameter implants, we can use the drill after. We don't need taper drill, we don't need cortical drill for each implant. Only if we have 4.5 diameter implants and we need to prepare the cortical bone, we can use this one. But if we have 3.5 or 4, and we need to prepare the cortical bone a little bit more in the D1 bone, we can use the drill after. This drill initial that is wider is for under prepare the 3.5 for the same concept. If I want to under prepare a 3.5, I can use the initial drill, but initial drill is straight 2.5 millimeter. So you need to prepare the cortical bone, initial drill, cortical for 3.5, and place the implant. But remember, 90% of the cases, 85% of the cases, the final drill corresponding to the implants is perfect. D2, D3 bone. In case of D4 bone or D1 bone, we can over or under prepare very easier with this kit. Another two considerations before moving to the clinical cases. The drill as the stop. Sorry, this is 5. So here you have the stop. The mount as not the stop. Why? Because the mount apply very high torque. If the template is a little bit tilted due to the soft tissue movement, etc., when the mount go down, can create a lot of tension. If we want to make a little bit more, screw the implant, and we torque with the stop, the risk is to move the template if we go with the stop. Without a stop, we have a little bit, a very high less tension. How I have to stop? Flat, flat to flat, drill and template. Very easy. Making the yellow line in the slot and go flat to flat. But if I want to go a little bit deeper, I can. If I want to go flat, I can. Without the stop, allow to be more accurate and to avoid any kind of distress on the template. Last but not the least, when you put the implant can touch the bone here, for example. The mount is not guided. I suggest, you will see on the video, to enter in the reverse mode. When the mount is guided, to move to the forward. Why? Because if you enter it in the reverse mode, the implant is not engaging the bone. When you go at the reverse, the implant sit in the hole in the perfect centered position. After that, you change in the forward and the implant will engage. I will explain again these tips during my presentation. Steven, are you see my screen now?
Yes, yes, doctor, we see the screen.
See the presentation.
Yes, correct.
Okay, so don't worry because I will repeat some tips during the preparation, but I wanted to focalize that. I'm sorry, maybe I can go like this so you can also see me. Share again. Okay. Perfect. Okay. I will give again these tips during my presentation. We already saw Laura in the previous webinar. I will go very, very fast. This is the initial situation. Some oplet teeth in the upper and lower jaw. This is the radiographs. What was my diagnosis? Extraction of the oplet teeth, immediate complete removable denture before implants, not immediate loading after extraction, not immediate implant, sorry. Why? Because the patient remain without function, without teeth for a lot of years. So it's very important, particularly in the complete arch restoration, before to create the aesthetic and the function in the correct position of the mandible and of the muscles, and then place the implants. Because if we place the implants in advance, the risk is that the maxillary mandibular position is not correct. And then when we modify the maxillary mandibular position, the implants are not in the good prosthetically driven position. So I wait 4 months, then cross mounting and final prosthesis. At this point, when I have the perfect relationship between maxilla and mandible, muscle in the rest position, I can go to the plan. For this case, I use an external marker to align CBCT scan and STL file we saw in the previous webinar at the correct vertical dimension of occlusions and the correct centric relationship. In 1 minute, this is the plan very, very quickly. We saw the software in the last week, but as you can see, now I put the transparency of my STL. I positioning the implants in the anterior, straight and parallel between them, to implant in the posterior tilted with a multi-unit abutment. This is a all-on-4 according to the original protocol. 3.5 millimeter diameter in the anterior, 4 millimeter diameter in the posterior, with 4 multi-unit abutment. As I told you before, this is a perfect all-on-4 implant planning. Moreover, in this case, I also plan bone reduction. These are the anchor pins. I suggest at least 3 anchor pins, but 4, 5, sometimes is better to give more stability. So this is the plan. As I told you before, I plan bone reduction because the implant, look here in the crest, is very thin, and also I need some more space for my prosthesis. This is a multi-piece guide, as I showed you before. This is the base guide, like this. You can see in the picture-in-picture. This is the base. And over the base, I can put several modules. In fact, another name of this guide are modular guide. For example, this is the module for immediate loading on the index, but I will show you in the video. This is the module for the implant placement on your left, the module for the index or immediate loading on the right. And this is a very nice customized impression tray for final restoration, but I will show in the next webinar. So these are the guide, multi-piece guide, base, implant portion, index portion. You can see also here STL file and models. And you can see how the base of the surgical guide works like support for the temporary restoration. And on the right, you can also see a metal reinforcement. The combination of milled, PMMA, and metal are tested in the model and pre-assembled. Moreover, here you can see 3 stops in order to allow the temporary restoration to sit and stop on the base of the surgical template, making rebasing and immediate loading very easier. At the end, my dental technicians painted the temporary restoration with pink and white aesthetics. I performed 3 years ago the surgery. In order to show you 3 cases, I have 10 minutes for each case. So unfortunately, I need to go a little bit quicker. However, we are maybe preparing some platform that will allow you to see on demand the video, I hope in a short future. So keep in contact with us to improve our education. This is the base of the surgical template and the index portion. I need the index portion to stabilize in occlusion the surgical template. And these are the posterior anchor pins. The base portion, that is the portion of the surgical template that I fixed in the patient mount, allow me to open a flap within the base portion. Then, as you can see, I removed the base portion to elevate the flap. However, in the last period, we have some metallic sleeves that allow me to elevate the flap without removing the template. After the flap was elevated and fixed, I put again the base portion with or without the index. So now I have my base portion fixed, the flap was elevated, so I can start the bone reduction. As you can see, I put my drill flat to flat on the guide because the guide was designed to give me a reference for the bone reduction, 3 millimeters of bone. So just I put flat to flat the drill on the guide and I know how much bone I need to remove. Very, very easy. I love piezo surgery, but you can do with forces, with drills, whatever you want. In this case, I have 4 lines and then just to connect the line between them. Very interesting is that in the posterior area, the bone reduction is not parallel to the bone crest, but is tilted because it's parallel to the implant platform. So I will not need any kind of bone profiler in order to remove some bone around the implants to allow the sitting of the prosthetic components. As I told you before, after that, I remove the surgical template and just to connect the pre-prepared line in the bone, free connection, one on the right of the patient, one in the middle, and one in the left. This is a view with the camera on the glasses. And this is the amount of bone to be reduced, but was already calculated in the software. So all implant placement and temporary restoration are calculated after the bone reduction. Another benefit of the bone reduction is that we have a very flat and wider bone crest. So we have two benefits. The first is anatomical point of view, wider and flat bone crest. Flat bone crest is also very helpful for the hygiene maintenance. And from aesthetic point of view, I have more space for the pink materials. After the bone reduction, I put again the base of the surgical template, just to refine. And this is the implant portion. This is the initial drill I showed you before. Do you remember in the kit, initial drill, shortened drill that allow me to prepare the first 5 mm, allowing the double contact for the next drill. So the next longer drill will contact the prepared bone and the surgical template, because it's very important that the drill is guided. This is the longer. Look here, inside the bone, I have a double contact, one in the bone, one around the surgical template. Without the initial drill, the drill will touch the bone before it is guided. This is the second, third, and fourth. After that, after all the sides were prepared with the initial drill, and look here are perfectly in the middle, just to improve the quality of the bone, I prepare with some bone expander asset kit from Ostem that has some tools for expansion of the bone, but also bone reduction. In this case, I use this expander because are calibrated for Ostem implant. And this is the first way to improve the primary implant stability of my implants. The second way will be to use a more conical implants, TS4, in order to improve again the primary implant stability, because here we are in the maxilla only for implants, and I remove some hard bone in the crest. So I need to improve the primary implant stability of my implants. As I told you before, expansion of the bone and more aggressive TS4 implants. Bone expander increase in diameter. After the bone expansion, I put again the implant portion of the surgical template in order to guide the implants. Now the multi-guide are fixed. Look in the picture in picture, are fixed with some screw. In this video 3 years ago was just fixed without screw. Now I am preparing just the crestal portion of the implant because the bone expander was used free end. So I could ovalize a little bit. I have the immediate loading, just use this drill to make the holes a little bit more precise according to the implant loading. So I repeat my preparation: initial drill, longer initial drill at the working length, bone expander, shorten final drill. This is the implant. This is the TS4 that is more conical. This means it's more aggressive. And as I showed you before in the reverse mode, and then in the forward mode. Maybe you can see better in the anterior implants. Looking at the yellow line that must be visible, reverse, and then forward. Look here. When you enter with the implant, the mount is not guided because the implant is long. So the risk, look here, on the left, you are more moved on the left. If you go on the reverse, you can center the implant. When the implant is centered and the mount is guided, you go forward. And this is the yellow line that must be positioned in the slot. Like this. But you are free to place the implant with the mount flat to flat, a little bit deeper or not, depending on you. This is the second implant. And the second anterior. And the last. Again, I want to show you reverse mode and then forward when the implant is fixed. After implant placement, multi-unit abutment. Very often we need to use the bone profiler. Bone profiler is a tool that allows to remove the bone around the prosthetic component, because if you have some bone peaks, prosthetic component doesn't fit well. However, here we have a bone crest, so we don't need the bone profiler. 2 straight multi-unit abutment in the anterior, 2 tilted multi-unit abutment in the posterior, 70 degrees. Dental Lab can give you some guides to place the multi-unit abutment in the right way, or if you have a little bit experience, you can do. 1 multi-unit abutment, and the second tilted multi-unit abutment. So at this point, we have placed the implants and the multi-unit abutment. This is the temporary titanium link. I just test my temporary restoration that is perfect in the holes. Remember that the temporary restoration is metal reinforced. However, if you place the temporary restoration like this, you have several possibilities to fix with the base. If you remember, you have 3 stops, 1 in anterior and 2 in the posterior. Look in the anterior, in order to fix the temporary restoration in the correct vertical dimension of occlusion. If you use the antagonist, you can find the correct centric relation, but without the upper stops in the base of the surgical template, you cannot find the correct vertical dimension of occlusion. A very benefit of the guided surgery is to prepare in advance the temporary restoration. So the rebasing phase to delivery the restoration are very easy and quicker. As you watched before, just to test, now cleaning with some saline, I need to fill the titanium temporary restoration with some Teflon or cotton, whenever you want. Then, when you can, I suggest rubber dam, avoiding metal resin goes in the bone. If you are flapless or with a mini flap, maybe you don't need, but if you have all the maxillary opened, maybe the rubber dam can make everything more safe for the patient. Then you put some resin and rebase around the temporary abutment. For this procedure, I use conventional acrylic resin. Then remove the resin, remove all the temporary restoration. The titanium abutment are fixed in the temporary restoration, just to check. In this case, for the live surgery, I sutured the patient mouth and my Delta technician refined the temporary restoration. How do you refine? You need to fill with the flow composite resin close to the temporary restoration if needed to remove excessive resin and to polish. Because in this case, most of the temporary was pre-planned and prepared in advance. Then very easy to put again the temporary restoration and to check again the occlusion. This is the temporary restoration. You can see also the X-ray with the antagonist and the occlusal area that is perfectly the same of the planning. Another case, another live surgery last year in Rome. This is the patient, 62 years old with some medical problem, but nothing special. She extracted the teeth due to periodontal disease. However, also this patient had a very poor prosthesis. So I started again from the beginning. I extracted 2 teeth and prepared a new prosthesis. This is the radiograph. This is the situation after the extractions. And now ready for the CBCT scan and STL scan with the new prosthesis. The new prosthesis was used as a temporary restoration for the patient, but also to guide the surgery. For this case, performed together with headquarters in Korea, we used 3 shapes. This is a short video, 30 seconds of the planning, the antagonist, the prosthesis, implant position, 8 implants, also in order to deliver 3 different bridges, for example. In the maxilla, I use all on 4 in case I have not so much bone, or 6 to 8 implants in case I have bone. This is the plan, and this is also the plan of the temporary restorations. These are very interesting tools, are some radiopack tools that are used in the surgical template before implant placement in order to check the final implant position. Because you know that from planning to the real surgery, we have some discrepancy. In this case, we can check the final implant position without any kind of discrepancy. And also we can print a model and prepare in advance the temporary restoration. For this case, we prepared 2 types of temporary prosthesis. One Korean style, cemented on pre-milled abutment. One European style, screw retained on multi-unit abutment. However, what is the difference? If we have the soft tissue that can be customized, maybe customized abutment are better than multi-unit abutment. However, customized abutment allow to perform cemented restoration. In Europe, we prefer screw retainer restoration. However, for your convenience, we tested both cemented and screw retainer restoration. And this is the video of the multi-titanium base that we use to fix the temporary restoration on multi-unit abutments. This is the type of the prosthesis. Unfortunately, I need to go very quickly also here. In this case, we perform flapless approach because we tested in advance the prosthesis, and we also, as I showed you before, make another test of the final implant position. As you know, as I teach in the previous webinar, I love flapless approach, but it's not always possible. Very, very often we need to open the flap because we don't have a sufficient amount of bone to be safe and sufficient amount of keratinized tissues. If we are sure that our planning is accurate, our surgical template is accurate, and we are sure that we have bone and we have keratinized tissue, we can go flapless. In this case, we use the mucotum before placing the anchor pins. After to use the mucotum, then we need to remove. So we have prepared 8 holes. After that, we can put the guide and fix. In this case, we have screw retained pins. As you know, in the original kit, the original pins are screw retained. In Europe, very often we use pushed pins. What is the difference? Screw retained pins are more accurate. However, I can remove, because if I remove and put again, I lost stability. Pushed pin, as you watched before, are a little bit less accurate. However, I can remove and put every time I want. So depends of the type of surgery we need to do. In my kit, I have both. The preparation is the same I showed you before. This is the pins. Initial drill. In this case, we use this drill. I try to stop, or I can maybe put here. Just 1 second. Okay, this is the flat drill. What does it mean, flat? Means that is to reduce some bone in the crestal area. We have narrow and wide. If, as in the previous case, I plan bone reduction, of course, I don't need this drill, of course. In case I don't plan the bone reduction, the flat drill allow me to remove some bone through the implant way to make implant placement, also the drill, using the drills and the prosthetic component easier. So I suggest the flat drill in case of deeper implants if bone reduction is not planned. So the drilling protocol is the same I showed you before. Initial drill, the final drill at the working length, and then improve in the diameter. All the implants in this case are TS4, so I can go to the delivery of the final restoration. Implant placement. All the implants are TS4, as I told you before. If you remember, and implants are with a soy surface. I try to show you. Soy surface is activated surface, is more improve the hydrophilicity and wettability of the implants, and the implants are a little bit more dark. I try to show you. Just look here. The implant is a little bit more gray, a little bit more dark, seems to be wet, in fact, are an hydrophilic surface. So all the implants are in place. As I told you before, in this case, we have two kinds of temporary restoration. These are customized abutment. The problem of the customized abutment is that they have an hexagon. They have an hexagon, so we need to fit and screw the abutment in the perfect position. We have 6 possible positions. In this case, we have 8 abutments. 1, 2, I go quickly, I'm sorry, because the time is finished for us. 3, 4, just test the temporary. 5, if you remember, 8 implants, 8 temporary abutment. These are customized abutment. Look at this picture. 1, 2, 3, 4, 5, 6, 7, 8. I'm sorry, pre-millet abutment. Titanium customized abutment, prepared and millet before the surgery. And the first temporary restoration. The temporary restoration fit very well. The margin is very good. And you can put a little bit of cement. A little bit of cement. The holes allow to place the abutment easier. Then we close with some fluid material. And this is the first temporary titanium customized abutment and pre-milled PMMA. However, as I told you before, we tested 2 temporary abutments. So we are removing the customized abutment and we are placing the multi-unit abutment. Look here, 1, 2, 3, 4. In this case, all the multi-unit abutments are straight, so it's very easy. Look at this picture, 8 multi-unit abutment. In this case, we are screwing the abutment. In this case, we have titanium-based for multi-unit or different type of temporary abutment. And the same, the fit is perfect. In this case, in the previous case, some cement, we need to remove the cement in the patient mount and close the hole. In this case, we can put resin, we can rebase with the resin, and then we can unscrew all the temporary restoration, refine in the lab or in the clinic, and then screw again. Also, in this case, the fit is good. So here, temporary and acrylic resin, refine and screw again, as I show you in the previous case. And this is the implant placement, very parallel between them. So, few seconds before the last case, in the first case, multi-piece guide, bone reduction, temporary restoration, screw retained. In the second case, flapless approach, 2 kinds of temporary restoration, titanium CAD-CAM and cemented, or multi-unit and screw retainer. This is last case with some post-extractive implant. This is the planning, 6 implants, some post-extractive implant in the anterior. The situation of the bone is not perfect here. Here is a little bit better. This is a post-extractive, sinus lift, and this is the video. The video is 1.5 hours, so I go very quickly. This is the first guide to fix the pin, because we have the teeth. I can use the teeth to fix the guide because the teeth are very stable. As you know, accuracy of the surgical template in partial cases with teeth are more accurate than in the completed entulus patient, because the template can move. So this is the base of the template, and the modules that I showed you before is to fix to stabilize the guide and to fix the anchor pins. Extraction of the teeth. This is a metal ceramic work, so I need to cut and to remove. And you can see here the situation. Extraction of the top left teeth, some anesthesia. Mini flap, very, very mini flap, and the base portion again. In this case, I have 4 pins. These pins are pushed, not screw retained, because as you saw before, I can remove and put again the template. Mini flap, implant portion, initial drill. Remember, the initial drill is very important to prepare the first millimeter of the bone, allowing for the double contact. See here, the initial drill is immediately guided because it's short. Some more anesthesia. And this is the drill at the working length. The drill entered in the prepared bone and found, look here, I am looking for the double contact. Here I have the double contact. The drill entered in the prepared hole with the initial drill and then is guided also in the body. So this is the drill at the working length according to the plan. In this case, bone expander, as I showed you before, and a little bit more reduction. Implant portion to finalize the drilling protocol, as I showed you before. And implant, look again. The implant can move inside the hole. Reverse mode. The implant fit is auto-centered. And then I change when the implant is auto-centered. Very nice protocol. 1, 2, 3, 4 are 6 implants. I'm sorry, I go quickly. This is the bone profiler. As I told you before, if the implant is a little bit deeper, when I put the multi-unit abutment, but all the prosthetic component, including healing abutment, the prosthetic component can touch the mesial and distal bone because it's wider than the implant diameter. These are some guides that were screwed in the implant, and the guide allow a drill to prepare the bone around the implant without touching the implant because it's protected by this guide. Look at the drill. The drill is centered in the guide. I'm sorry for the camera. It's centered in the guide and prepare the bone around them like this. Look how much bone is collected. every time, except if I perform in advance a bone reduction, anytime I place implant deeper and have immediate loading, or I use multi-unit abutment with implant a little bit deeper, I really suggest the bone profiler in order to allow the perfect sitting of the component, prosthetic component. Bone profiler in all the implant, multi-unit abutment, as I showed you before, temporary abutment. But how you can see, I go a little bit forward. This is the metal reinforcement. I did another intervention this morning, 6 implant. I removed 3 implant, please 6 implant and temporary the same way. Metal reinforcement. Sorry, look here. In this case, the stops are here. 1, 2, 3, 4 stops in order to find the correct vertical dimension of occlusion. So we can make any mistake. How rebased? In this case, the flap is very small, so rubber dam is not needed. We need to dry very well, even if the resin is hydrophobic. The acrylic resin, I suggest to dry very well. Teflon inside the titanium link in order to avoid the resin go inside. I asked my dental assistant to prepare some acrylic material. I put a little bit around the titanium temporary abutments. And then inside the temporary restoration, the steps are resin, metal reinforcement, and then go in the patient mount. Now I'm filling the temporary restoration. There are also a lot of resin that can make polymerization with light, but are not completely hydrophobic. So every time I try to change material, I have some problems. So I prefer acrylic resin. This is the metal reinforcement. Also very interesting because in the first case, all of these were made before in the dental lab. In this case, directly in the patient mount. You can follow these 2 ways, depending of your agreement with the dental lab and your expertise. If you are not very well prosthodontics, maybe you can ask to the dental lab to prepare everything in advance, or you can management directly in the patient mount. This video is 90 minutes, 6 implants, tooth extraction, prosthetic component, temporary restoration, everything. 1.5 hours extraction, implants, and immediate loading with a very strong metal reinforced restoration. In this case, only 8 teeth because implant in the posterior, as I showed you before, there was 1 sinus lift and the stability was not so high. So I prefer to make immediate loading also in the 4 anterior implants. Look here, then you need to fill with some flow or very fluid resin some gaps and finalize the surgery. This is the sinus lift on the left. During my dental technicians is refining the temporary restoration, I place the implant in the posterior. 2 more implants, multi-unit abutment, and cover cap. This is the suture, and this is again the temporary restoration refined in the dental lab. In the same time, I place the posterior implants. 4 screws, just some occlusal retachment, and finish. In this case, a short arch, because in the posterior, as I told you before, there are second molar, so we have a lot of gap, second premolar, first molar, second molar, 3 wide teeth, and also no good primary implant stability due to the poor bone quality in the posterior maxilla, and also due to the sinus lift. So this is the radiograph immediately after implant placement and loading. You can see very, very strong metal reinforcement. And also look here, this is the reason why you need the bone profiler, because the diameter of the implants is narrow that the multi-unit abutment. So you need to remove the bone around the implant to allow the perfect fitting of the prosthetic component. So, Stevens, I am finished. I really want to thank Ostem Middle East, all the participants. As I promised, only clinical case, I'm maintaining my promise, I think. But I think it's very important, the execution, just some tips for the surgical kit, one guy kit, for the template without metallic sleeves that I really love, some tips for the drilling protocol, and for the immediate loading procedure. So thanks again, and if there are some questions, I will be very happy to respond. Let me know.
Yeah, thank you very much. Thank you, Doctor. I think it was very informative. Many people will have many different questions about multi-abutment, and when can they use the multi and screw retained or cement retained. So I think we could solve many confusion for many people.
Okay,
so
can you hear me? Yes. Okay.
Yeah.
Okay. So very, very, very nice question. And it's very funny because in the live surgery in Rome, the second case that I planned together with a doctor from Korea, he planned screw retainer, cemented retainer restoration, but European doctors use mostly screw retainer restoration. So I want just to clarify a little bit. First of all, regarding the multi-unit abutment. Multi-unit abutment are 2 benefits and just one thing maybe to improve. The benefit are that from biological point of view, allowed to perform the one abutment, one time concept. What does it mean? If we place the implants a little bit deeper, if we have a soft tissue transition zone, we can secure the implant straight immediately the multi-unit abutment and seal the connection, reducing a lot, close to 0, the marginal bone remodeling, and move at the soft tissue level all the screw and screw prosthetic tray-in, delivery, etc., moving upper the inflammation. This drastically reduce the marginal bone remodeling. We move from 0.5, 0.6 millimeter of marginal bone remodeling in 1 year to 0 if you use the one abutment, one time concept. But why we need to place this multi-unit abutment? Also for prosthetic reasons, because internal connection is fantastic from a surgical point of view, because the connection seal very well, no inflammation, and we can place the implant deeper. That is a benefit from a surgical point of view. But from a prosthetic point of view, it's not easy to compensate the disparallelism. So the multi-unit abutment converts the connection from internal to external, so we can have the benefit of the internal connection, implant deeper, seal of the connection, the benefit of the external connection, so this parallelism, and move the inflammation at the tissue level. The problem with the multi-unit abutment is the space, because the multi-unit abutment, the 8 is from 1 to 6 or 5, I don't know, but the diameter is 4.8. Is a little bit wider, particularly in aesthetic reason or thin biotype. For this reason, also Ostem also provided convertible abutment. Same concept, seal the connection, convert from internal to external hexagon to have both benefit of the internal connection from a surgical point of view and external connection from a prosthetic and biological point of view. And this is the reason why I convert the connection. Then cemented and screw retained. Also here there are benefit and some negative points. The benefit of the screw retainer restoration is first of all the retractability and also the space, because we have more space for the material for the prosthesis. But first of all, retractability. I can unscrew whenever you want to clean, to correct everything, to fix something. Cemented restoration, of course, we have the risk of the cement, but I want to be clear. We need to remove the cement very well, and we can. The benefit of the cemented restoration is the benefit of the CAD/CAM abutment, because we can customize the emergence profile. If you have multi-unit abutment, we cannot customize them because are standard. If we use the CAD/CAM abutment, single or multiple, we can customize the emergence profile, pushing, for example, the tissue through a papilla or not. We can customize pushing or not the soft tissues. Cemented restoration also allow to compensate this parallelism of the implants. However, the limits is the aesthetic in the emergence profile, because we need two components, abutment and structure, framework. But the most big problem is the retractability. If you need to remove, is not, sometimes it's not easy. So then in Italy and in Europe, today, most of the restoration are screw retained. Also are maybe a little bit more economical, but I'm not sure of this point of view. Other questions, Stephen?
Thank you. Thank you, Professor. Yeah, I think it was informative. I also have a frequent question about when can we use multi and a convertible abutment? When can we use this and when can we use that?
As I answered before, honestly, in my experience, I always used multi-unit abutment. So I prefer multi-unit abutment because I know them better than convertible abutment. But the concept is the same, to convert internal to external connection. When we need, when the implant are disparallel, for example, more than maybe 20 degrees, we need to convert. And if we want to move the movement of the prosthesis, screw and unscrew at the tissue level. In this case, we can screw immediately multi-unit abutment or convertible abutment, and then take impression and try in on the second abutment. Another benefit of the multi-unit abutment is that they compensate about 40-44 degrees, but we also have tilted multi-unit abutment, 70 and 30. So with the multi-unit abutment, we can convert also 100 degrees of this parallelism, a lot. So, but the concept is convert internal to external connection, to improve the biological benefits one abutment one time, to allow to correct this parallelism of the implants in case of disparallel implants. Maybe convertible abutment in case of white aesthetics, if you don't need pink aesthetics. Multi-unit abutment, classical all on four, for example, if you need to put pink aesthetic. Or if you need to convert very tilted implants, multi-unit abutment. Okay? Other questions, Stephen?
Yes, I think that's all. I think the answer was clear. So thank you very much. Okay, I think that's all the questions we have.
Perfect.
Mm.
As
Okay,
always, if there are other questions they wrote to you, you can send to me and we will answer in the next webinar. The next webinar, we will speak about finalization, impression, digital impression, and CAD/CAM fabrication of the final restoration. Single, complete, arch, and we have a couple of webinars on this topic. We can see all the cases that I showed you in the previous webinar, the final part. Most only clinical cases and a few slides. Okay.
So this is our next meeting for the next month.
Okay.
We will be waiting. Okay.
Perfect.
So
thank you very much.
Thank you. And we are also waiting to see you in February. I will announce
Yes, of
about
course.
the Austin meeting.
I can wait. I can wait.
Yes. So
the location is amazing.
Yes. So this will be a big event. So we are also expecting everyone to come personally. And Professor Marco is also invited. So you can see him in person there. So it will be February 5th, 2024, next year, February. So I think we are all done now. So thank you, Professor,
again.
very much. And we will
Thank
be waiting for
again.
next webinar.
Yes, see you soon. Bye-bye.
Thank you. See you soon. Thank you, everyone. Thank you.